Now this will be the con of the con. So I don't have anything to disclose. You know, I was here in 2005 at the first meeting, and Tony asked me, I was a young surgeon, I think 4 years in practice, and Tony asked me to give this same talk in the presence of some pretty big names, and at that time it felt like this. And I'm not sure today it really quite feels the same, although I will say I've been doing this talk for a long time, and the data on lumbar total disc replacement is certainly been impressive and well documented, but still leaves open some questions. And one of those questions this year is, if it's such a great thing, you know, here at this meeting, which is the big meeting about motion preservation, we're only devoting one small section to it, and even in the tech talks, there's really, I don't see any lumbar discs over there in the tech room. So I'm sure you'll hear in the next talks about the ills of fusion, but not every patient who's fused gets adjacent segment disease. This is one of Tony's patients who I got to see 13 years in follow-up last year, who had some motion-preserving device in the back, and you can see there is a solid fusion and no adjacent segment disease. This is one of my first patients in practice. You can tell by the instrumentation I was using at the time, 21-year follow-up with really no adjacent segment disease and solid arthrodesis. So standalone ALIF is, I mean, this is a new thing. This isn't your grandmother's ALIF, and I think that's something that we need to focus on when we're talking about these patients. These aren't these types of cages, it's these types of cages, and these are modern cages, and you'll see why there's some problems with it. And we know that when we compare these to a 360 fusion, there's no question that they work a lot better. And you look at the ODI scores, which I want you to remember, is a 360 fusion is giving you ODIs in the 28, but the standalone is now bringing this down into the 20s. And then yet another paper that shows the benefits of doing the standalone ALIF compared to what the past. So the problem here is, though, that when we look at all our great data on lumbar disc replacement, we're comparing it to 360 and some other inappropriate fusions that really aren't using today. There's no question that they do better. But I also want to remind you that to look at some of these scores on the ODI, and oftentimes we're seeing scores in the 30s. Now, and that's usually the inclusion criteria for patients with back pain going into these studies with moderate disability. So it's not a be-all and end-all, and of course Dr. Kebby already showed that the 5-year results really, it wasn't really clear if there was really a good outcome, and that's perhaps because we're comparing it to a 360 fusion, which is really not comparable. I almost like to see in the boardroom when they decided to use the 360 fusion as a comparison, there must have been a lot of rollicking and laughter. But this is not cervical disc replacement. This is not radiculopathy and neck pain. This is low back pain, and that's the patients that are getting this device. And herein lies the problem. So we know that these are probably the worst patients that we see in our practice. These patients often have so many issues beyond a degenerative disc. Some of them barely even have a degenerative disc. And these are not generally the candidates that you want enrolled in your research. There's Dr. Kebby at the end of the day seeing one of these, a whole day of seeing lumbar pain. This is what the result winds up. But when we look at what the indications are for, these are the strict indications. These are the IDE criteria. This is the best we can do, and this is what's in the literature. And so you look, these are pretty strict, but they get even more strict as time goes on. So that was back in the IDE days of 2005. But now we look at, we're getting now, it's psychological issues, a lot more. So I look at this patient who came to see me after they had surgery with failed back pain syndrome, and this is what they looked like before surgery. And this was a discogram trying to search for the pain, and then this was the end result. And so we wonder why those patients don't do well. And so now we're having more policy statements, and look at these criteria now for indications and exclusions. They're starting to be like pages and pages long now. Here's the NAS guidelines. Again, this is not just simple dark disc disease. There's a lot of inclusion and exclusion. So the whole point is trying to define the ideal patient for this device. And that might be very hard to do in the end. So we have to look for the primary pain generator, which we know is almost impossible to find. Discography is not really in vogue anymore, so how do we really find these patients? And then when we look at the ISASS policy, now they've come to a conclusion and agreed that that should mirror the selection criteria from the IDE studies. Well, we know that the majority of patients these days getting disc replacement do not mirror that criteria. We know that that criteria is very difficult to find. In the early studies, Kamisa studied, he looked at this a long time ago, and so many patients have contraindications. And this was done again more in a private practice setting in which only 5% of patients lacked the contraindications to having a disc replacement. And of those that were indicated, most of them were work comp and disability patients, which again are difficult patients to operate on anyway. Now, Dr. Blumenthal's group might think differently because they have a particular bias where they feel that many fusion patients actually are candidates for TDR, but these are very difficult patients to find. So when I look at a patient, why am I going to want to do a disc replacement versus a standalone? I think there is certainly indications overlaps, but in the end, we're going to need to really further define what this indication is. What kind of surgery does this patient get with chronic back pain? And so if we want to just look quickly at some of the data for the standalone ALIF, the data is great. It takes the osmometry down to 25, 30. I mean, this is comparable to all these studies with 100% fusion rates with BMP, very comparable to disc replacement. And this, again, here's more and more studies with the standalone. Again, not your grandmother's standalone, but standalone devices as they are today, which have wonderful outcomes when patients are selected properly. Again, this is comparing two-level in which the lumbar fusion surgery wasn't even done very well with fusing patients in kyphosis, still did about the same as the hybrid disc replacement. So. And then finally, this study looking at Maverick versus, so disc replacement versus standalone, there's really no difference in ODI when they were in results. So again, I ask you, when this patient comes to your office with chronic back pain, really, what are you going to do? I'm not sure we have that answer today. There are some things that I think stand out to me. The current standalones are very good options. I find that in a non-ideal patient, which probably is 95% of the patients, I think it's a better option. I think there are better options for you when there's clinical failure, not instrumentation or surgical failure. I think we always have to remember that these IDE studies that now have 10-year data, 15-year data, kind of come up on 20-year data, are all based on these inappropriate studies with non-inferiority. And again, this is where all our long-term data is coming from. And I think finally, importantly, is that when we expand the indications for disc replacement, when there's been no scientific rigor, I think that's when we get in trouble with both patient outcome and when we're trying to get these approved by our patient. And since this is a debate, I know Dr. Kohler is coming up next. I follow him on Instagram. I think he's a master of this medium, and I learn a lot about disc replacement, and I thought you might want to learn some of his own words before he speaks to you in a couple seconds here.
I try my best to never perform fusion of the spine and avoid it whenever possible. Sometimes it's not avoidable. If I have to fuse a level in the spine, I try to sandwich it between two artificial discs. So I call this the ADR sandwich.
So we're going to see the data on that coming up.